Hello there, glad to have you join me on the program On the Spot. My name is Aaron Isaac. You say, despite effort and commitment plus funding to eradicate a disease that is as old as human existence, TB remains endemic, especially in developing countries such as Nigeria. Nigeria is ranked 6th with TB burden, and all that it's doing is to ensure that it keeps its population safe and free from the disease. However, the fight is not coming to an end this quick, because obviously there are certain limitation that is holding Nigeria back. On the continent of Africa, 23% of TB deaths is reported and recorded here in Nigeria. So what is Nigeria doing differently to tackle the disease called tuberculosis? Well, we're here to dot the I's as well as cross the T's. We're here to further the conversation and set the agenda as the world marks World TB Day. We're speaking about these and other elements that are limiting the fight against TB in Nigeria on the program. On the Spot starts now. Occupying the 6th most burdened TB nation in the world, that obviously would put Nigeria maybe perhaps top on the continent of Africa, with 23% of the deaths reported or recorded of TB on the continent of Africa registered to Nigeria. That puts it as a scary note for every stakeholder that is working towards addressing the issue of tuberculosis in Nigeria. Of course, there's no doubt in mind that Nigeria has done significantly well in addressing the issue of TB. Not just Nigeria, Adamawa State has scored, huge points in also addressing the issue of TB. But there's so much work to be done, evidently. And how do we go about addressing that much work that is needed to be done? Well, let's pull in someone who has a very, very significant knowledge about the TB program, how it's been and how it's faring, and where it's taking us to. Let's pull in Dr. Stephen John. He is a board member, International Union Against TB and Lung Disease. He is the Director of Planning, Research and Statistics at the Ministry of Health. Plus, of course, he is the founder of China Health Foundation. Dr. Stephen John will be talking to us about this lovely afternoon. Thank you very much, Dr. Stephen John, for joining me on the program.
You're welcome.
It's indeed a big delight. With vast knowledge, and you've been part of this program for a very long time, for decades now, and I bet you know a lot about tuberculosis. But please, let's set the foundation, let's set the premise for this discussion. Help us understand why TB is a disease that should concern everyone today.
Well, thank you very much once again, Aaron. TB is a very, very important public health problem, not just for Nigeria, but for a number of countries. Okay. And you've said one very important thing in the introduction, talking about Nigeria's position in Africa. Yes, we are number one. We are number one because of the burden of TB, the number of people living with TB within the country. It is believed that annually, despite all the effort, we are still missing. That means not able to get to diagnosis. Over 300,000 people living with TB. So that is very important. You've spoken also about a high proportion of deaths. Yes, considering the fact that we have high number of people living with HIV, and also those that have predisposing factors to tuberculosis infection. Again, that adds to the whole picture. And at the end of the day, it becomes so important for us to address it. And we know definitely addressing the problem of TB requires a lot of effort from different stakeholders because it has gone beyond the health sector. TB is not just a health problem.
Okay.
You can look at it from the social perspective. You can look at it from
the economic perspective.
Exactly.
Also, yes.
So these are the issues. So TB is very, very important.
What are the signs and symptoms? Say, for instance, for a layman, how do you detect that this person has TB, for instance, and how do we go about reporting such kind of cases?
The commonest symptom of TB is cough. We say cough of 2 weeks or more. But of course, going forward with the researches and all those things, some people even start coughing today. In a week's time, you can see that TB can easily be diagnosed.
Is that possible?
It's possible.
Okay.
It's possible because it's highly infectious, especially when you are in an environment where that promotes the spread of TB, like overcrowding, poor ventilation, etc. So cough is the first. Then you have fever. Then you have night sweats and then loss of weight. These 4 symptoms are the most important, principal ones. Then you have constitutional symptoms. For example, if someone has TB, which affects every part of the body, of course, TB of the spine, you expect to see a slight swelling over the area of the spine that is affected. That is called a gibbous. Then, of course, if someone has TB of any joint, you expect a swelling and then pain from those particular areas. Then you have other symptoms like loss of appetite, and feeling of ill health and all those kind of things. But principally, cough, fever, weight loss, and of course, night sweats. These are the common.
At any point in time, can any of the signs and symptoms be conceived to be maybe other diseases?
That is why we have what is called in medicine a differential diagnosis. So when you see these symptoms coming, of course, a doctor will now diagnose and make a diagnosis of TB and then say to rule out 1, 2, 3, something like that. So that's the other diseases suspected. But the good thing is that we have a high-tech molecular diagnostic tool that could easily make the diagnosis of TB in less than 2 hours from the time the sample is brought.
Let me drag you back a little bit. We said TB is as old as human existence because there's this piece of information you showed me pretty much earlier, 668 BC. And from an Assyrian library.
Yeah.
And the description, it matches what we talk about in terms of the signs and symptoms of TB today.
Yes.
How old is tuberculosis in a real sense?
Tuberculosis is very, very old. We're talking about 668 BC and all those things. This was even when they have gotten tired of seeing patients and studying what happens to the patient in terms of the symptoms that patients experience before they die, because at that time, the management of TB isn't as it is today. Because I remember there was a time, that was the period where people are taken to the sanatoriums and kept there and then given them food so that they can build like some immunity to fight against the TB. There were no medicines or good medicines at that time. So you can see how this has all evolved to a point that we have a treatment of a 6 months duration for non-complicated TB, and then for resistant TB of 9 months duration. That is to say, there's a lot of improvement. We compare this to the sanatorium days, to the days that only nutrition was seen as a treatment of TB. So a lot has changed, but TB is very, very old. But surprisingly, despite the time that has elapsed, in terms of this disease, today we are still battling with tuberculosis.
And that's what makes it interesting. Talk to me about why you think the fight is not being won against tuberculosis. What seems to be the bottleneck? What seems to be what we're not identifying, or what is it that would seem not to know about the disease?
It seems the disease is moving faster than we as healthcare workers and
so it's mutating and changing its presentation. Is that?
Besides that, TB is not the bacteria is not one that is very famous. Known with mutations or like that. But an undetected case of TB within 12 months can spread to 15 people. And I told you that Nigeria misses over 300,000 TB cases. If you just make a really simple arithmetic, 300,000, each one of them spreading to 15 people by the time it's 12 months. You can see the number that we're landed with. So much.
Huge.
So it's huge. So now, is the bacteria moving faster than us? Yes. Do we need to do something? Yes, we need to do something. We need to wake up. We need to attack it from all angles, not just healthcare workers. The private sector is there. Government is there. Other stakeholders, community leaders, even the youth in the community that are working as volunteers in different projects have a role to play. So all these things have to come together. And then, of course, we have discussed in the past what effort government has done. We have also discussed what we expect from private sector.
Sure.
If you pull together all these things, all these factors, all these efforts together, then we can talk about, yes, we can end TB in line with the theme of this year's World TB Day.
Now, give me a sense of why we're not having a conversation of TB presenting itself on the developing countries alone. We have some cases also represented or presented in developed climes. What could be responsible for the spread of disease? Is it not irrespective of status?
Yeah, actually, if you read through TB literature, you will see clearly that the lower socioeconomic class, people that are impoverished, people that are disadvantaged, people that live in slums, in key and vulnerable populations like the internally displaced persons, refugees, nomadic people, drug addicts, people living with HIV. This is where you have TB thriving so much. And this population is mostly found in developing countries.
So it's a pattern within developing countries.
It's a pattern within developing countries. If you read TB literature, they will tell you that almost 80% of the problem is in sub-Saharan Africa and all those low middle income countries. Not in the high income countries. Not that they don't have TB. There's TB in the United States of America. There's TB in other developed countries, but the numbers are very, very low.
Okay.
Because the level of knowledge, the level of education is high. People immediately they start coughing or they start feeling ill health. They go to the facilities. There's health insurance and all this. People don't even think of whether I have the funds to support my healthcare bid or all those kind of things. They go get checked, and if it is TB or whatever it is, they get treated. So because of this kind of proactive responses, because the society is ripe for that, But here, back to Africa, low middle income country. Our society is not yet ripe for that because we have people battling with ignorance, people that are not educated, a good number of them not educated, people that believe in alternative medicine, traditional medicine, when they have symptoms, the tendencies are high in some communities for them to patronize first traditional. Exactly. Then people that delay before they come to facilities. And because our insurance has not really gotten to a point that everybody can just walk to the facility, insurance is just coming up now. You have delays in presentation, they come very late, and at the end of the day, you have the high death rates that you're talking about.
Okay, now talk to us. Let's still come back on track to just build the basics for people to have an understanding of. Let's speak about the treatment regime for tuberculosis. Say, for instance, someone has been diagnosed to say, okay, you're TB positive and you need to be placed on treatment. What are the treatment regimes available for TB patients, and how affordable and accessible are the treatment regimes that we have?
The diagnosis and treatment for TB are free.
They are free.
They are free. They are free.
Like
Because
FREE free.
Exactly. No penny, no money is collected from people. If that happens, report it to the TB program. Just report it, because the drugs have been provided by Global Fund with support from Nigerian government, of course. The reagents are there coming, very free. The gene expert test, all these are free. The drugs are going to be given to everybody, 6 months for uncomplicated TB, 9 months for starting from the simplest resistant TB that we're talking about, then on to the complicated ones with tailored regimens. These are free. So this is what is happening. So I think that everybody should know that whenever they hear people pay for TB diagnosis or treatment, they should report it to the TB program. If not, come to the Ministry of Health. We have a Director of Public Health, report it to him. We all know in the Ministry of Health and the government of Nigeria that TB diagnosis and treatment is free. So it should be free. So that is not...
Has it been free all the while?
It has, from the beginning, it has always been free. I joined this program in 2002. I started working as a TB program manager in 2002. I've put in almost 14 years there before moving to Saka and the rest of them. I still have a lot to do with TB today. As you've heard, I'm a member of the board, union board right now. You understand? So this is something that is international. This is something that is all over, that TB diagnosis and treatment is free, except in developed countries. You know, where insurance has even taken it
It's taking
over.
care
They
of
don't
it,
even
yeah.
feel. They
Yeah.
don't even feel the
Now,
problem.
that's the paradox. If the diagnosis and treatment are free, then why are developing countries still burdened by TB?
There are issues. There are issues here. You know, besides this, the issue of access that we have been discussing, which is not an issue there, but the stigma. You still have some level of stigma.
Okay.
You know, if someone is coughing, go on a train in any developed country, any European country, go on a train and then you're coughing. You see people start turning away. You understand? Because somebody is coughing. Is it COVID? Is it TB? What is it? You know, like that. So that kind of feeling gets some people not to present quickly. That is one. The number two, in the developed countries, when people come down with cough, TB is not actually the number one thing they suspect. There's the flu, there's the cold,
yeah.
They all have present with cough. So the doctors, you know, kind of go through all these things before arriving at TB. So if you're unlucky, you're going to have like an extended amount of time before getting picked. And number three, by the time it is picked, assume this guy has been there with TB for a couple of months. Who has it spread it to? And there are people that are not, you know, it takes time before they come down with the symptoms of TB. Let me reveal something to you that is very important, that is frustrating the fight against TB. We conducted a prevalence survey here in Nigeria in 2012. The prevalence survey showed us that of the people diagnosed with bacteriologically positive TB, those that are positive on sputum, 40% of them were asymptomatic. That means they didn't show any symptom.
Yeah.
It's just X-ray that shows some lesions, and then samples were taken and they were positive for TB. What am I saying? Me and you are seated here. I'm not coughing, you are not coughing.
Sure.
I could have TB, you could have TB.
Exactly.
Real frank TB, I'm talking of full-fledged TB, not the primary infection. No, there's something we call primary infection. If you walk through a hospital, you inhale the bacteria, you get the primary infection, they do a MAN2, it shows a reaction, it shows that you have primary infection, but you don't have active TB. The bacteria will remain in check.
It's just going to be docile
for
there.
all the days of your life if you don't have anything that brings down or lowers your immunity.
Okay.
You understand?
So it's a question of immunity.
It's a question of immunity now. It's a question of immunity. This one, the primary infection. But the full-fledged...
Can such people transmit it?
No, they can't.
They can't transmit.
They can't.
Okay, so I think we're safe a little bit there. Because
yes, we are safe.
I was about to be worried about transmissibility.
No.
Okay.
But guess what? 20% of such people, like me and you, at the end of the day, that's the latest modeling, what it shows now. 20% of us are going to come down with TB in our lifetime. Active TB. Because by the time they say active TB, that means that bacteria that is kept under check in the latent state will start multiplying and rearing its head and presenting with symptoms in the people it manifests.
And of course, we have to bother about the decline in your immune system, because definitely with time, with age, as you continue to age.
Exactly. Age is there, HIV is there, poor nutrition.
Poor nutrition is there,
you know,
all
diabetes,
like,
people with other comorbidities, you know, people that are drug addicts taking a lot of drugs, you know, like that. Even prolonged antibiotic even lowers the immunity. So there are things that lower immunity. So if in you and me, who are here in an endemic place, I know that we have the primary infection, but we're healthy, of course. If our immune system lowers, don't be surprised, TB will be the next thing that comes out.
Wow. So it's a silent killer.
It is a silent killer. It is a silent killer. And that is why now it is very important that the world is investing in high-tech, you know, technologies like the portable X-ray that has artificial intelligence, that you can go to the community and screen the entire community in one day. You can shoot up to 200 X-rays. It will read it and score it and give you the probability whether it's TB or not TB, so that you can investigate further. Okay. Now, in this group, there are some people that don't even show symptoms, but lesions will be seen. So this is the only way we can pick part of that 40% that I spoke about. In India, it is 50%, where they're worse off than us. 50% of people with TB in India, you know, are symptomless. They don't show symptoms.
Now, why do we see India, for instance, being rigorous with its campaign towards addressing TB? And in some other parts, it appears the attitude seems to be lukewarm towards combating the problem. So give me a sense of why India is placing a lot of emphasis towards addressing this problem.
It's not the case of having the wrong attitude or something. India is a very, very big country. India is a hub of science. India is like the capital of the world in terms of TB, because they have the highest numbers ever. They have all the resources it takes. But India is one of the countries where you have the highest rate of stigma to TB and other
That's the
stigmatizing
stigma
disease.
which you mentioned
Exactly,
pretty much earlier.
Exactly. That stigma plays a big role there. And number two, they have this caste system in their society such that people that are belonging to a particular tribe can easily be ignored completely because they belong to because of the caste system. So those kind of factors play into disease control, not only TB but even other diseases. And then remember, just recently, I think it was from last year, even now they have not come out of the woods yet, India has a big shortage of anti-TB drugs and then diagnostic agents and all those kind of things. They are battling it out. There were a lot of civil society uproar, there are a lot of letters, a lot of communication with the prime minister, and finally they said the drugs are coming in now. Remember, they also manufacture, but what they manufacture is not even enough to take care of.
Yeah.
Exactly.
Now, speak to me about what gives birth to the stigma. Is it because of the linkage between, because I know before now we speak about TB control program in tandem with leprosy control. Could that be the reason why there is this stigma, attached to
Once you have a disease that has a cultural dimension to it, a disease that you find cultural translation in its meaning, like tuberculosis, like leprosy, you are born to have stigma because they have branded these diseases. Remember, first, TB is a very old disease. If you read that description from the king of Assyria that I share with you, he was describing the symptoms, that the breathing of that particular patient is like a flute. If you just go through, and then he said a lot of things about how warm the extremities are, how cold. Can you read it?
This is a patient coughs frequently, has sputum. His sputum is thick, and sometimes contains blood in it. His breathing is like a flute. His skin is cold, but his feet are warm. He sweats greatly, and his heart is much disturbed.
Yeah.
When the disease is extremely grave, he suffers from
Diarrhea.
That
describes typically what they were seeing, and up till today, if people present very late, those that could not access.
So you find this.
You still find this. Well, you will wonder why the diarrhea is there, because the immune system has broken down completely. So now other infections are coming to stimulate other symptoms in people. You can see, the heart is troubled. When you see a typical TB person with TB who has come very late to treatment, who is emaciated already, by mere looking at his chest, you will see how the area
of course,
where the heart
affects one key organ, the lung.
Exactly.
If the lungs is not functioning very well, obviously they had to have a problem.
Yes, of course. But most importantly, you will see that just the area over the heart is like moving, like that. So now these people in the medieval, they say the heart is disturbed.
Yes, there will be irregularity in the heartbeat.
Irregularity in the heartbeat so fast, and then you have warm torso but cold torso but warm extremities and all this, So all these are what contributes to the stigma of TB. TB has been linked with evil spirit. TB has been linked with a lot of different causes. But the myth and misconception around TB are the things that build up to this stigma of TB.
So part of the slow growth and progress that has been made can be linked to the myth and misbeliefs that are tied to TB, therefore.
Yes,
and beyond just creating awareness, part of the awareness creation will have to be one that will have to give people new orientation of what the disease is all about.
Perfect. Research has shown that all those myths and misconceptions, first of all, if you want to attack a problem of TB in community A, you be sure you find out what are the cultural drivers of tuberculosis in that community, including the drivers of stigma. Whatever myth they have, whatever misconception, it's very important for you to integrate this into correct knowledge so that when you're broadcasting your messages, they will hear from the community that yes, that evil spirit that they think causes TB is not the case. It's not true. Okay. TB is a bacterial disease. Some people say TB is not curable, but TB is curable. Some say it is only prayer houses or babalao or the traditional healer that can cure TB. Of course, that is not true. Medicines are there that are used now to cure TB completely. And also, it is very important to include TB survivors, people that have survived TB, in the campaign. If you're recruiting volunteers, Exactly. They will share their stories and let them be people, if possible, from that particular community where you're working, so that it's evidence that they knew, yes, once upon a time he was down, he had TB, and now he's up and healthy.
Okay. Now, let's still talk about the treatment regime. If someone is placed under treatment, what is the gestation period? What is the time frame for such person to come off the treatment? And what has given birth to what we talk about drug-resistant TB today?
Two things you ask now. If somebody is placed on treatment, the duration is 6 months. But it is very, very important at the beginning to let the person know. That is why there is treatment counseling. You tell them, okay, you've been found to have this disease, tuberculosis, but nothing to worry about. It is a curable disease. We're going to give you treatment, and the treatment lasts for 6 months. And of course, these are the periods, like at the end of 2nd month, at the end of 5th month, like that. These are the periods that you're going to be required to get a sample to be tested again, just to measure the progression of the disease and all that. So all this has to be built into the discussion. And at every contact that the healthcare worker has with this newly diagnosed case who is now on treatment, opportunity has been taken to really educate them more so that they remain adherent to treatment and achieve the cure. And they need to know that if they skip treatment, then they are playing with the chances of getting cured, because drug resistance comes out of interruptions in treatment. This is one of the causes of drug resistance. So that is very important. So it's good to pass this particular message. And then the second question was?
What brings about drug resistance? Because obviously it's something that is a new nomenclature that we talk about today. That we have persons who have developed resistance to drugs. Treatment does not work any longer in them. So what could have given birth to this?
Several factors. Several factors. Yes, of course, the bacteria has a tendency. Every bacteria has a tendency to mutate. That means they will be resistant to a particular drug out of the 4 drugs that are used for the basic treatment. If they are resistant,
so we have 4 drugs for the basic treatment.
Okay, and these are non-complicated TB. So the names are very important.
Okay, of course.
So these 4 drugs are there. We avoid going too technical. Like that. So if there's a resistance to any one of them, commonest one that people see and the abuse is rifampicin. Rifampicin is being used to treat gonorrhea and sexually transmitted diseases in the past. And because of how indiscriminately people use this drug, it has come, for instance, if they use it to treat urinary tract infection in a person that has TB unknowingly, already the bacteria will have a taste, have a feel of rifampicin. So when the D-Day comes for the diagnosis of TB and the treatment, you will see that it's not uncommon to have this particular person being resistant already to rifampicin. So that is already a problem. See how drug resistance develop. So that's one. Then number 2, skipping the medicines. When you skip, it's supposed to be daily dosage. They weigh you, and then based on the weight of the person, they give you 2 tablets a day or 3 tablets a day. It has been simplified. It's not like before that you take 20 tablets, 15 tablets. It's now fixed dose combination. So if you're supposed to take 2, 3, 4 tablets exactly as prescribed, take them at the right time regularly. If there is a mistake from the healthcare worker and he gives you 2 tablets instead of 3, it's a problem. It can cause resistance because the amount of concentration of drugs going into the body to treat the disease is not enough again. So the bacteria will still survive, and once it survives it develops a means of bypassing that some of the injurious effect on the bacteria within itself. And then at the end of the day, it doesn't respond to the medicine. And there is one very surprising thing that is responsible for drug-resistant TB. This one, it was after a year or 2 that I started seeing this thing in my TB career. You see this weighing scale that they use in the clinics. Honestly, it's good for the healthcare worker to know his or her weight and be checking that scale, because some of these scales are not correct.
I think I had an encounter. Where I had to climb. First off, I climbed the analog scale, and it wowed everybody. And then we tried the digital, and the digital scale gave me 2 different results. It was quite confusing because we did not know what to make use of any longer.
So it's a problem. If you know your weight, I know my weight, I'm 87 kg right now, so 86, 87, that's how it is. So if I go to a facility like this, I go on supervision to check what they're doing, I go on the scale. Once I see that it is like 70 something or 80, I know that it's cutting that weight. Once I see that it's 90, I know that's not my weight, so there's a problem. So you use your own weight as quality control. This is what you're supposed to.
How many people have this kind of knowledge?
It's experience that brings it. But
So I know, yes, I know. And they say experience is a mother of invention. But then again, how many people would understand this? Because you are a specialist, you can easily do this.
So at least during supervision, we try to make it clear to healthcare workers to use this particular means to make sure that they know they put the people on the right dosage, which is based on the weight. Yeah. So if they miss that weight, it will cause problem. And then that could be a cause of resistance.
The question I want to put before you is why 6 months for the treatment, Dr. Stephen John? Why not less than 6 months? Why must it be 6 months?
Science has shown that what is needed, to treat TB fully, uncomplicated TB, is 6 months of the drugs.
So it's a question of science now.
Science, yes. And it is not the same treatment all through. The first 2 months is the whole 4 drugs. Rifampicin, isoniazid, paracetamol, and etamitrole. 4 of them. There are 4 drugs in the fixed dose combination the first 2 months. Then the next 2 months is 2 of these drugs. Then the next 4 months is 2 of these drugs. So 2 plus 4 is 6. Okay. So this is the treatment for uncomplicated TB. But if it is a complicated TB, for example, resistant TB, then the duration becomes longer. And that is very important. So, and then of course, talking about shorter regimen, there are researches that are going on right now.
All right.
That are trying to improve on the regimen. Okay. In fact, off the record, not off the record, still on record, there's a drug that is close to being released that will cut up to 4 months out of this treatment. But they are working on it. Right. There are various of them, various drugs that are being worked on. Same thing with vaccine. I think I must have mentioned somewhere that vaccines, there's a lot of research also going into vaccine. But it's unfortunate that the funding for this research and development in TB control, in prevention and care, has not been as ambitious as the funding into HIV, into malaria, into other viral diseases. And this is one thing that we want to change going forward globally, so that people can commit, government, private sector, and everybody can commit funds to this particular research and development.
Now, you talked about 2 kinds. You said complicated and non-complicated. Yeah. We've used them loosely, but we've not been able to clear the air on why they are described in this particular manner. Yeah. When we come back from this break, we're going to take a break. When we come back from the break, you will speak about why we have these 2 categories, complicated and non-complicated. Then we will talk about the global campaign. Annually, there is an observance on the 24th day of March where the world comes together to once again do, some of a ticking of boxes, how far we have done, what do we give ourselves a pat on the back, what are the level of success is recorded, how's the leadership response like, what about the partnership, how are they coming in with the resources, what about the funding, where do we need to scale up, and what do we need to do differently to win the fight against TB. We'll be talking about this when we come back from the break, but that's going to be the second chapter. Well, you're watching on the Sport Live, and yes, you could hear vast knowledge coming to play here on the discussion of TB and what we are doing to win the fight against tuberculosis. Yes, of course, we have the willpower to end it if we choose to act. We'll be back with this conversation with my guest. I hope you stick around.
I need the police that can respond to emergencies first.
I want the equipment I need to do my job.
I want a police that won't harass or arrest me for no just reason.
I want to be valued for my work, not feared by honest people.
I want a police that won't ask me Anything for the boys?
I want a decent salary that is paid on time.
If it happen with good laws
Proper funding.
Training.
And cooperation.
if it happen.
If it happens.
If it happens.
You're still watching On the Spot live from our studios here. If you want to be a part of the program, you can visit our Facebook page plus our YouTube page and to follow up conversations that we've had earlier before now on that platform. Plus, of course, you can be a part of the show by dropping your questions, comments, and suggestions to the number 08069380191. Not entertain calls. We only take questions on that. So you send SMS alone to that number. If you have a question, you have a comment, you have a suggestion, you can drop that on that particular line number, which I just read out, 08069380191. Yes, what's before us on the front burner today? We're taking a look at the journey so far in addressing a public health issue in Nigeria, which is talking about tuberculosis. Are we winning the fight? Are we dropping the numbers? Is Nigeria becoming less endemic of tuberculosis? If yes, then we'll say good news. What about global campaign? What are we doing? Is the world really on track in addressing the issue of tuberculosis? Well, these are the issues that we're taking a look at. And I have a member, International Union Against TB and Lung Diseases. He is a board member. And of course, he is the Director of Planning, Research and Statistics at the Master Ministry of Health. Plus, of course, he's the founder of China Health Foundation. He's been into these for a very long time, more than 2 decades. Everything about TB, something that revolves around him. And so we're having a conversation with him. Dr. Stephen John is still my guest at the moment, and then we're taking a look at this. Dr. Stephen John, once again, let's get back to the conversation. Before the break, I said we've talked about it loosely. We talked about complicated and non-complicated. And then someone maybe perhaps is wondering, I've not heard him really describe what is this complicated TB and what is uncomplicated TB. Could you just, for the benefit of the viewer, just help us, briefly explain what you meant by complicated and non-complicated?
All right. So, you can broadly divide TB into two.
Common sense will tell us.
Yeah, of course, you have the drug susceptible TB. That is the simple one. This one, you have the bacteria. They are very responsive to the basic 4 drugs I was speaking about, and the treatment of this one is just 6 months. You have a 2 months of intensive phase where you take all the 4 drugs. Then you have a 4 months of the continuation phase where you take 2 out of the 4 drugs. Okay. So this is the non-complicated one because this one is a drug sensitive. Right. Then when you start talking complications, then you start looking at drug-resistant TB. But sometimes, even before getting to the resistant part, you look at TB that affects very sensitive part of the body, severe TB. TB of the brain is complicated already. TB
so
is already
TB of the brain.
TB of the meninges, meningeal TB of the brain. Then you have TB of the heart layer, TB carditis we call it. That is also can be a very bad one. Then you have disseminated TB also. That means the TB has spread in the body, in the whole of the lungs, you see it all over, around the body, it's spread already. You have TB of the spine also. That one can put somebody from walking in a week, the next week is on a wheelchair, he can't use his limbs again. Okay. All those. These are also forms of complications that come with TB. But don't be surprised that even with the complications, this bacteria might still be responsive to this particular drugs that I mentioned as drug-sensitive TB. Okay. But drug-resistant TB, you have the bacteria being resistant to either 1, 2, or even all of the drugs that are being used. Yeah. So now if you have that, then the treatment changes completely. The basic drug-resistant TB that we have, the treatment is 9 months. But the complications can go beyond this, because even among resistant, there is more resistance than there's total resistance now that people, the measures that has been taken to manage those will even marvel you, because every drug that is available that at our disposal, the person can have that bacteria that is resistant to it. So in the resistant patterns, you have different types, and the treatment durations differ. But mark one very important thing is that it's a longer duration of treatment with resistance.
Okay, now talk to me about something the world is doing annually, 24th day of March. We see the world come together to once again reflect on the journey so far. Speak to me about the kind of global commitment towards addressing this issue of tuberculosis. What is it like today? Is it one that is poised towards ending tuberculosis in its real sense beyond just mere political rhetorics?
I think so. I think that the global response is fair and is moving towards, with the will, like the belief that yes, we can actually end TB. Now, if you look at globally, very important events that took place from last year, for example, not just even last year and previous year, the United Nations high-level meeting, they call it, that was held in New York in the US, is a meeting that brought together, leaders from high-burden countries, to this particular gathering. And in this gathering, you have experts who have analyzed data of tuberculosis across the world and broken them down into targets in terms of the number of people that are supposed to be detected every year, those that are supposed to be put on treatment, and then of course number of people that are supposed to have the preventive therapy, the TB preventive therapy, the number of children that are supposed to be detected and put on treatment. And besides breaking it down, the targets, they now broke it again by country so that every head of state goes home with his own target and then goes to sit and talk with his TB program to see how they can address the target. So this is a very good move from the global level. And there are other moves also. You have the Global Fund, you have the Stop TB Partnership in Geneva, providing technical support to different countries, in terms of refining and redefining and optimizing their TB responses within the country. This is also something that has been going on. Right now, as I'm speaking, I think tomorrow or next, we're going to receive them. They're going to come to Abuja also. They're going to confer, there's going to be investiture on the wife of His Excellency, the President of the country, like the TB advocate, champion, that's what they're going to do. So they're coming with a lot of things.
So this conversation are going beyond table to the field, to action.
Exactly, to action. So, and then of course, they're going to remind them of the UN high-level meeting targets again. Because we need to really act to meet these particular commitments. And to meet the commitments, there has to be, of course, 2030 is the first, but people are talking again beyond that, 2050 again. So funds needs to come. You understand? Domestically, from the government, from the partners, from individuals that are wealthy. Bill Gates has given has been given money. We have our own Bill Gates here too, who can also, you understand,
invest in that program. It's good you made mention of funds, because fund obviously is something that we need. Say, for instance, we had a stall during 2019, the COVID-19 period, where resources had to be distributed in different lines to address the issue of COVID-19 as at that particular time. How significant is funding to the fight against TB, and what would be your message? Because it's like regional governments are relaxing in this stead, in actually sticking their necks out to bail out or to provide resources also to cater beyond what the global partners are actually doing.
Funding is very critical in the sense that now we have loss of skills. We have healthcare workers that are out there in the facilities whose capacity has not been built to be able to promptly detect people with TB and place them on treatment. Besides that, we have issues about general quality of care. You may have the drugs, you may have the reagents, but sometimes people might need something else. Look at the hardship that is going on and all those kind of things, So funding is required to optimize the quality. We need supervision, we need on-the-job training beside the residential training that is given to healthcare workers. We also need to harness and leverage on community resources. For example, there are lots of youth in the community that have gone through secondary school, some have not, but they can contribute so much to the response for TB prevention and care. As volunteers, different organizations are recruiting this, and then of course they give them stipends, to make sure that they are able to kind of carry the message and carry the fight to the doorstep of the community. We need to engage with the community leaders also, so that they own up to the program. Local ownership,
bringing in the issue of ownership there.
Exactly, local ownership is very important, and that's the earliest sign of sustainability. Sustainability is not only just funding coming domestically, but you have to have ownership. Funds can come domestically and they might not be able to make the impact because there is no ownership. Exactly. So these are some of the things that needs to be done if we have to change this. But right now,
do you think this is coming alive in the thinking? Say, for instance, we're speaking about Nigeria, and maybe perhaps we can narrow it down to Adamawa State. Do you think perhaps this actually is forming the basics for the thinking of the national leadership towards this response against TB, as well as what's going on here in Adamawa State?
Not like as much as we want. But Adamawa State is even a better example compared to other states. Because, for example, now, first, you need the infrastructure to deliver the service. We're excellent in infrastructure. The facilities are there everywhere. You've heard about the 403 facilities, the PHCs in the 226 wards that work 24 hours with well-staffed and all those. They are there. But, but we need capacity building. Okay. The staff in those facilities, the last time they were trained, if you ask, might be 5 years, might be 6 years, 7 years, or 8 years, they need to be retrained, because a lot of changes are taking place in TB prevention and care now, which they need to know, Okay. And then, of course, in those days, I remember there used to be healthcare workers from the facilities used to go to the community and carry out health talks. This doesn't happen anymore. And we need this now. Within the communities.
Within your over 2 decades of working within this particular environment, so what would you say is missing in terms of commitment towards addressing or ending tuberculosis? In terms of your viewpoint, what is it that you've observed, and what do you think are the ways out towards addressing the problem? Mitigating the problem?
There are a number of things. First, I start with the healthcare worker. The mindset is no longer the same in a good number of healthcare workers. In those days, you are happy that things work. You are seeing supervisors from time to time come in and pat you in the back, telling you, well done. You are seeing the result of your handiwork in that little facility that serves 3,000, 5,000 people in your own community. These days, you don't even see the supervisors. So the healthcare worker has become like demoralized. He's working and nobody is checking, and he loses interest in this work. That is very important. Number 2, in those days, you used to have periodically, after every 3 years or so, they say, send a list of people to be trained for TB. Now, there ain't no funding again to do this training. Training is not happening as frequent as it needs to, despite the fact that you have changes in the TB prevention and care platform globally. So people need to catch up with that. Again, you have community involvement. This is something that was so strong in the past. I mentioned already here how healthcare workers used to go to the communities and raise awareness on health issues, including tuberculosis. This doesn't happen routinely anymore. We need to start that all over again. The most importantly, we mentioned the issue of funding. How much domestic funding can we raise? What can the private sector contribute to the response to TB control? There's a lot of funding gap there. We have the infrastructure. We have a number of staff there. In fact, where there are staff shortages, we could complement using community resources, the volunteers at the facilities. We have the ward development committees who could look into this and provide names of people from the community to support in those facilities. But can we build their capacities?
Dear friends, colleagues, and partners, as we come together to commemorate World TB Day, we stand in solidarity with the millions of people who fall ill with TB each year, and remember the millions who have lost their lives from this preventable and curable disease. We would like to salute all the health workers at the forefront of the fight to end TB and other diseases, including communities, civil society, and advocates, national TB programs, partners, and donors for their tireless dedication and support to the fight to end TB. This is a pivotal moment for the global fight to end tuberculosis, or TB. We have strong commitments with concrete targets made by world leaders in the political declaration of the second UN high-level meeting on TB held in September 2023, which provide a strong impetus to accelerate the TB response. 2024 is a year of action to ensure these commitments are met and millions of people benefit from life-saving TB prevention and care services, saving lives. While global efforts to combat TB have saved an estimated 75 million lives since the year 2000, TB still remains one of the world's deadliest infectious killers. Each day, over 3,500 people lose their lives to TB, and close to 30,000 people fall ill with this preventable and curable disease. This preventable and curable disease continues to place an enormous human and societal toll on those affected, their families, and communities. Last year, WHO reported that there has been a significant recovery worldwide in the scale-up of access to TB diagnosis and treatment services, with the highest figure diagnosed recorded since WHO began global TB monitoring in 1995. It shows an encouraging trend of progress. There is some progress as well in the development of new TB diagnostics, drugs, and vaccines. However, this is constrained by the overall level of investments in these areas. WHO Director General Dr. Tedros Adhanom Ghebreyesus officially launched the TB Vaccine Accelerator Council in September 2023 to facilitate the development, availability, and use of new TB vaccines. The Council aims to identify innovative, sustainable financing, market solutions, and partnerships across public, private, and philanthropic sectors. The theme of World TB Day 2024, yes, we can end TB.
We're having a conversation with a board member, International Union Against TB and Lung Disease. He is also Director, Planning, Research and Statistics at the State Ministry of Health and founder, General Health Foundation, speaking about a public health problem. Now, before now, we should have surmounted, but unfortunately, we're still grappling with having to work our way around the disease. We're referring to tuberculosis. Annually, the world marks World TB Day on the 24th day of March. And we're trying to do a bit of review also, an assessment of how far the journey has been globally to address this public health problem. And I'll still have Dr. Stephen John here with me on the program. Doc, let's still get back to the issue. Earlier, you talked about funding and ownership. For me, I think it's a critical component which we need to think about from our own ends as a people. But I just want to bring up something that I just spotted while Nigeria was marking the day. I talked about TB in children. Just how much worries should we have, regarding TB, manifesting in children? Is there any need to worry?
Yeah, of course, there's a lot to worry about. Children are actually they have lower immunity, especially those that are less than 6 years old, and a good number of them die because of tuberculosis. And unfortunately, it's so difficult to make a diagnosis of TB among children. Now it has improved a bit, because in those days, before the coming of the gene expert, the doctors have a hard time making a diagnosis because they don't present with typical symptoms.
Okay.
And that is the problem. It is known that up to 15% of all TB, people with TB, is projected to be among children. But in Nigeria, we're detecting 6-7%, which means there's a good number that we are missing already. Okay. So it is very important to put make every effort, to make sure we get them to treatment. But with the improvement of diagnosis now, for example, in the people 0 and 5 years now, stool is being used in gene expert to make a diagnosis. Okay. This is just recent, it's not more than 2 years that this has started here. So that means it has we successfully reduced the window of difficulty, in the diagnosis. But then people have to still be able to identify the symptoms of TB in these children and then, and then investigate them. Okay. And that is where, again, you have difficulty because of the atypical kind of presentation. A child might just refuse to eat. A child must just lose weight. You don't expect to see cough and all those kind of things like in the adult, in a lot of, even when they have it in their chest. So this makes things difficult. Okay. But they are delicate, and it's very important. We put more effort to get children.
Now, speak to me about the role science and technology is playing in medicine right about now to help, advance, propel the changes that is required to happen in ending tuberculosis globally. How interesting is the journey been so far?
Well, it is interesting because if I look at 20 years ago when I started, a lot of things that are in place now were not there. Yeah. And these are all product of research and development. But I mentioned earlier, I think that still the funding to support research and development in tuberculosis prevention and care is limited compared to what is available to other diseases like HIV, like malaria, and the rest of them. But so far, at least each year that we have the World Union Conference meetings where different countries, the Federal Ministry of Health together, they come together with the TB unit to come and showcase what they've achieved, what they've done, to come and learn from each other, to come and network with manufacturers of those particular important equipment for TB diagnosis. You see encouraging things. Okay. For example, I mentioned to you already the most common one now that WHO has approved is the use of the digital X-ray that has artificial intelligence. Sure. But this is for 15 years and above. There's still research going on for children. To make sure that there are no ill effects. But of course, the researchers were very, 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 very fantastic, wonderful in the sense that this particular portable X-ray is not like what you have in the facilities that emit so much radiation. It's just like a camera.
Reduced radiation?
It's reduced so much.
What about accuracy?
Very accurate also. It's just like a camera. Like you put people together and snap a picture. That's how it is. You take a picture of someone's chest and you have the chest X-ray with a reading that tells you the probability of TB. So that is very important. And there are other things also. Like for instance, now you go to other countries. Even in these countries, it has been tried where you have the tablets, in a sachet like this, having some reminders on them that beeps when it is time to take medicine, to take their medicine, just to remind people, to that it is time to take your medicine. So that way it helps the people that are especially elderly, who don't have support, and even some young that are stubborn in quotes with to remind them to take their medicine. That promotes adherence. You have what they call video dots also, where a short video is taken to show to the healthcare workers that yes, the drugs have been swallowed. Although of course there are concerns about privacy and all those kind of things around that. So a lot of changes have taken place, and then research is going on also, like I said, to get drugs with a shorter duration of treatment for drug susceptible or drug resistant TB, and also to get the vaccine, for tuberculosis, which will help the whole of sub-Saharan
we say it's a public health problem, which means it comes to its own consequences, therefore, because it leads to a breakdown of the socio-economic fabric of the society. In terms of creating awareness, how much do you think needs to be done in that particular regards? Because awareness jingle, trying to educate the public about TB, what to do, what to know, seem to be on the low, especially in developing climes like Nigeria.
You're very correct.
What do you think we need to do to scale up the campaigns?
You're very correct. I think we need to sustain that, but then there's a mistake that we're making. You cannot have one jingle or one statement or phrase or whatever for the whole that will fit and make fit the whole country. One shoe doesn't fit. One shoe cannot fit all.
So it's not a one-size-fit-all thing.
It's not a one-size-fit-all thing. Thank you for that correction. Now, I mentioned earlier about community perspectives to TB, which differs from region to region. And I mentioned also the importance of integrating myth and misconception into common knowledge so that we can attack that stigma in community A, which is different from the stigma in community B, which means for a state like Adamawa State, the jingles that we broadcast here for tuberculosis must not be the same with the jingle that should be broadcast for Bauchi State, because you have differences.
Now, that's talking about the peculiarities of these areas.
Exactly. Right. But unfortunately, what is happening is we have a national jingle. It's one, TB is curable, treatment is free. Anywhere you see the sign of that, stop TB, go, that is a dot center. But it doesn't talk about the misconceptions, doesn't talk about type of the myth. So these people in the community that continue to patronize traditional healers will continue to. But by the time you bring out those factors that make them patronize traditional healer, maybe there is a tinge to the whole story that evil spirits are responsible for TB. Then you bring it to the jingle and say, okay, TB is not caused or has nothing to do with evil spirit. You are speaking to that particular community that believes.
The global campaign says, yes, we can end TB.
Yeah.
Are you as optimistic as the visionaries of this particular campaign that yes, TB can be ended?
With the right leadership, if we're able to put the United Nations high-level meeting, commitments right in front of us as leaders, and then follow up with commitment in terms of resources domestically from the government, from the private sector, and then topped up by what is coming from international donors, I think, yes, we can end TB.
Okay, so next time when I'm bringing you, we're going to look at the different dimension we need to take towards supporting global funding for TB program and what we need to do in terms of scaling up strategies locally to help source funding for TB program, especially here in Adamawa State. Dr. Stephen John, always a delight. Thank you so very much.
You're welcome.
All right, so you've heard it all. TB is treatable as well as curable. We just have to, develop a positive mindset towards its treatment and keep the myths and misconception aside. Just believe in the science, and I believe we'll get there one day. It's a matter of time. Thank you for your time and company on the program today. Let me see you again next time. So come your way with a fresh package of the program. My name is Aaron Isaac. Do have a blissful day.